Hello everyone, welcome back to KS Medical Coding Academy. In this lesson, we will learn about critical care coding in Captain Evaluation and Management Services. We will cover the definition of critical care, coding guidelines, time requirements, reportable procedures, Captain code selection, and practical coding examples. By the end of this lesson, you'll have a clear understanding of how critical care services are coded in both Medicare and non-Medicare settings. Before we begin, this training is for educational purposes only. Always refer to the latest CPT, ICD-10CM, HCPCS Level 2 manuals, payer policies, and official coding guidelines when assigning medical codes. Welcome to Lesson 8 on Critical Care Evaluation and Management Services. In this lesson, we will learn what critical care means according to Captain guidelines and understand the difference between a critically ill or critically injured patient and a stable patient. Next, we will review the official critical care coding guidelines and learn how physicians report critical care services based on the total time spent providing direct patient care. We will also discuss the differences in time reporting for Medicare and other insurance payers. You will learn which procedures are included in critical care time and which procedures should be reported separately. Finally, we will review coding examples, CPC exam tips, and knowledge check questions to strengthen your understanding and prepare you for the CPC certification exam. By the end of this lesson, you will have a solid foundation in critical care (EM) coding. In this slide, let's understand the meaning of critical care. According to Captain guidelines, critical care is the direct delivery of medical care by a physician or other qualified healthcare professional to a critically ill or critically injured patient. A patient is considered critically ill when one or more vital organ systems have severe impairment, creating a high probability of life-threatening deterioration if immediate medical treatment is not provided. Critical care is not determined by the location of the patient. It can be provided in the emergency department, intensive care unit, hospital ward, or any other appropriate setting. Common examples include patients with respiratory failure requiring ventilator support, severe shock, cardiac arrest, acute stroke, kidney failure, severe liver failure, or serious metabolic disorders. These patients require constant monitoring, rapid decision-making, and immediate medical intervention to stabilize their condition. Remember, for the CPC exam, critical care depends on the patient's condition and the intensity of the physician's work, not simply where the patient is being treated. In this lesson, we will learn the 4 major coding elements of critical care. These include the place where the service is provided, the total physician time, procedures performed on the same day, and reporting critical care with other EM services. Critical care services can be reported in different locations. The most common places are the emergency department and the inpatient hospital. The patient's condition, rather than the location, determines whether critical care can be reported. Critical care coding is primarily based on physician time. If less than 30 minutes of critical care time is documented, report the appropriate EM service. When the physician spends 30 minutes or more providing critical care codes are used. Time reporting. Critical care time differs slightly depending on the payer. CMS and AMA have different initial time ranges, but both use additional time increments after the first reported period. Sometimes procedures are performed while providing critical care. Some procedures are included in the critical care service, while others must be reported separately. Correct documentation is essential for proper coding. Included versus excluded procedures. Included procedures are considered part of critical care and are not billed separately. Excluded procedures have their own Captain codes and may be reported separately when documentation supports them. A patient may receive both an EM service and critical care on the same day. Proper documentation is necessary to determine whether both services may be reported according to coding guidelines. Reporting summary. Before selecting a critical care code, always review the place of service, physician time, procedures performed, and whether another EM service was provided on the same day. These elements help ensure accurate critical care coding. It is possible to report an evaluation and management service on the same day as critical care, but certain conditions must be met. The EM service should be provided before the patient's condition became critical. It must be medically necessary and clearly documented as a separate and distinct service. The documentation should not duplicate the work performed during the critical care service. If these requirements are met, Both services may be reported according to CPT guidelines. When reporting both an EM service and critical care on the same day, accurate documentation is essential. The medical record should clearly indicate that the EM service occurred before the patient became critically ill. It should also demonstrate that the physician performs separate work and that the documentation is not duplicated in the later critical care service. Proper documentation supports accurate coding and reimbursement. Critical care codes are selected based on several important factors. These include where the service is provided, the patient's age, the total physician time, and whether the payer follows CMS or AMA guidelines. Let's review each category one by one. Outpatient, ED, critical care. For emergency department patients of any age, physician time determines code selection. If less than 30 minutes of critical care is provided, report the appropriate EM service. If 30 minutes or more is documented, critical care codes are reported. Time reporting varies slightly between CMS and AMA guidelines. Both use CPT code 99291 for the initial critical care period and add CPT code 99292 for each additional 30 minutes when appropriate. Critical care for patients younger than 6 years. Patients younger than 6 years do not use the standard adult critical care codes. Instead, CPT provides age-specific code sets for newborns and pediatric patients to accurately report critical care services. For critically ill newborns from birth through 28 days of age, CPT uses neonatal critical care codes. Report CPT 99468 for the initial day and CPT 99469 for each subsequent day of critical care. Pediatric critical care codes vary by age group. Infants from 29 days through 24 months use CPT 99471 and 99472. Children older than 2 years but younger than 6 years use CPT 99475 and 99476. Pediatric critical care codes vary by age group. Infants from 29 days through 24 months use CPT 99471 and 99472. Children older than 2 years but younger than 6 years use CPT 99475 and 99476. For patients 6 years of age and older, adult critical care coding rules apply. Physician time determines whether an EM service or critical care code should be reported. Critical care services are time-based. The physician reports CPT codes according to the total documented critical care time. Although CMS and AMA use the same CPT codes, their initial time ranges are different. Let's review both coding methods. Under CMS guidelines, if critical care time is less than 30 minutes, report the appropriate EM service. Once the physician documents 30 minutes or more, CPT 99291 is reported. Additional time is reported with CPT 99292. As physician time increases, continue reporting 1 unit of CPT 99292 for every additional 30 minutes beyond the initial period. Always ensure total time is clearly documented. AMA guidelines use a different initial time range. CPT 99291 covers 30 to 74 minutes, and CPT 99292 is added for each additional 30-minute interval after that. For prolonged critical care under AMA guidelines, continue adding CPT 99292 for every additional 30 minutes after the initial critical care period. Accurate time documentation is essential. When reporting critical care services using CPT codes 99291 and 99292, several procedures are already included in the payment if they are performed during the same critical care period by the same physician. These services should not be billed separately. Additional procedures that are included in critical care reporting include gastric intubation, temporary pacing, ventilator management, and several vascular access procedures. These are considered part of the physician's critical care work. Not every procedure is included in critical care coding. Procedures that are not on the included list may be billed separately when appropriate. In addition, hospitals and facilities may have different reporting rules, so always follow payer and facility guidelines. Critical care coding is based on the total physician time spent managing a critically ill patient. If an included procedure is performed during this period, its time is counted as part of the total critical care time and is not reported separately. Let's look at an example. A physician spends a total of 40 minutes providing critical care, including 10 minutes interpreting a chest X-ray. Because chest X-ray interpretation is an included procedure, those 10 minutes remain part of the 40-minute critical care service and are not billed separately. If the physician performs a procedure that is excluded from critical care, the time spent performing that procedure must be deducted from the total critical care time. The excluded procedure is then reported separately, while the remaining physician time is used to determine the appropriate critical care code. When documenting critical care services, the physician must record only the time spent providing critical care. Time used for separately reportable procedures should not be included in the documented critical care time. In this example, the physician documented 40 minutes of critical care, excluding the 10 minutes spent performing an endotracheal tube intubation. Since the procedure time was already excluded, report 40 minutes of critical care and bill the ETT procedure separately. In this example, the physician documented a total of 40 minutes, but that time included 10 minutes spent performing an endotracheal tube intubation. Because ETT is a separately reportable procedure, those 10 minutes must be subtracted. The final critical care time becomes 30 minutes, and the ETT procedure is reported separately. Critical care coding depends on both the patient's setting and age. Outpatient critical care is always time-based. For hospitalized patients aged 6 years or older, coding is also based on time. However, for inpatients younger than 6 years, critical care services are reported on a per-day basis. Modifiers are important in critical care coding. Modifier 25 is used when a significant and separately identifiable E/M service is performed along with another reportable procedure. Modifier 59 may be required when an included procedure is performed during a separate session on the same day. Some procedures may be reported separately with critical care services. For example, chest X-rays with 3 or 4 views can often be billed separately. ECG or EKG services are also not included in critical care and may be reported separately when appropriate. Remember that CPT Codes 99291 and 99292 can be reported for patients of any age in the outpatient setting when critical care requirements are met. Always review payer-specific rules and ensure that physician documentation supports the reported services. Abnormal laboratory values are important indicators of critical illness. These results help physicians recognize life-threatening conditions and determine whether the patient requires critical care services. Let's review the major laboratory categories. Severe electrolyte abnormalities can affect vital organ function. Extremely abnormal sodium, potassium, calcium, magnesium, bicarbonate levels, or a critically low platelet count may indicate a life-threatening condition requiring immediate medical attention. Arterial blood gas testing evaluates respiratory function and acid-base balance. Critically abnormal PCO2, phosphorus dioxide, oxygen saturation, or pH values may indicate respiratory failure or severe metabolic disturbances requiring critical care. Other laboratory tests are also important in critical care. Low hemoglobin may indicate severe blood loss. Elevated troponin or CKMB suggests cardiac injury, while extremely high or low white blood cell counts may indicate severe infection or bone marrow disorders. Critical care interventions are medical treatments and procedures performed for patients with life-threatening illnesses or injuries. These interventions require continuous assessment, rapid decision-making, and intensive physician management. Several emergency procedures are commonly performed during critical care. These include management of major trauma, chest tube insertion, burn care, cardiopulmonary resuscitation, defibrillation, cardioversion, and pericardiocentesis when clinically indicated. Critical care also includes advanced medical management such as administering multiple intravenous medications, treating acute coronary syndrome, providing ACLS medications during cardiac arrest, therapeutic hypothermia, and non-invasive respiratory support using BiPAP or CPAP. Patients with severe trauma, head injuries, life-threatening burns, coma, shock, drug overdose, or severe body temperature abnormalities often require immediate critical care interventions to stabilize vital organ function. Other life-threatening conditions requiring critical care include thyroid storm, Addisonian crisis, cerebral hemorrhage, new-onset paralysis, and status epilepticus. Airway procedures such as endotracheal intubation and crocothyrotomy may also be necessary to maintain adequate breathing and oxygenation. In this case, a 67-year-old Medicare patient presents to the emergency department with pneumonia and respiratory failure. After evaluation, the physician determines that the patient is critically ill and requires immediate critical care management. The physician documented pulse oximetry, blood gas analysis, ventilator management, and a total of 90 minutes of critical care. Accurate documentation of physician time is essential for selecting the correct CPT code. The correct answer is CPT 99291. This patient received critical care in the emergency department, and the physician documented 90 minutes of critical care time. Pulse oximetry, blood gas analysis, and ventilator management are included services and are not reported separately when they are part of the critical care encounter. In this scenario, a 25-year-old patient who is not covered by Medicare presents to the emergency department with chest pain. During the visit, the patient's condition worsens and becomes critical. The physician spends a total of 90 minutes providing one-on-one critical care. During the critical care encounter, the physician interpreted a 2-view chest X-ray, performed endotracheal intubation, and placed a temporary transcutaneous pacer. These procedures must be evaluated to determine whether they are included in critical care or separately reportable. The correct coding is 99,291.25, plus 99,292.25, and 31,500. Because the physician documented 90 minutes of critical care, both 99,291 and the add-on code 99292 are reported. Temporary transcutaneous pacing is included in critical care and is not billed separately. Endotracheal intubation is separately reportable using CPT code 31500. Modifier 25 is appended to the critical care EM service to indicate a significant, separately identifiable service. Let's quickly review today's lesson. We learned what critical care is, when it can be reported, and how to select the correct CPT codes. We also discussed time-based coding rules, included and excluded procedures, critical care interventions, and practical coding examples. Mastering these concepts will help you accurately assign critical care codes in real-world medical coding. Thank you for completing this lesson. We hope this session has improved your understanding of critical care coding and increased your confidence in applying CPT guidelines. Continue practicing with real-world coding scenarios, and we'll meet again in the next lesson.